You know, this is the good point. When you are doing a conference, you can talk as much as you want. Nobody will stop you. You know, this is part of the privilege. So you have to tolerate me until the end of the day, God help. So thank you, Dr. Hussam, for the nice introduction. So we're going to have to talk the end of the day. What is it? Okay? What's going on? What do we need to do with this talk that we are trying to learn about fetal cardiology? How we can make the link between the fetal, the OB, the parents, the pediatric cardiologist, the NICU, the pediatrician. This is the end of the day that we have to make that connection. So this lecture really, to a good extent, is what I'm going to say to the parents, but more importantly, what I'm going to say to my other colleagues on how we're going to handle congenital heart disease. When Dr. Gowrie told you that about a patient will be delivered at King recently, it took a lot of turbulence, a lot of convincing, a lot of talk just to make the hospital feel it's okay, you can do that, it is not the end of the world. As a matter of fact, that what we don't understand, the fetal cardiology or the patient with the most critical congenital heart disease, they are probably the easiest one when you look at them. As a matter of fact, they look normal, as we said in the beginning, because they have a PDA and they have BFO, and they are just doing very well after birth until some significant hemodynamics to change. So we're going to talk a little bit about all of these kind of things. So fetal circulation. All what you need to know, even if you didn't remember all the fetal circulation, you need the worst situation, whatever the clinical diagnosis. You just need to keep the baby physiology as before birth. That's it. If you achieve that in somehow, some way, then the baby will be fine until the time of the surgery. So there is only one thing that you need to keep the PDA. I think you all, Dr. Sartorius is up there. You have to keep it open in the worst clinical scenario. If you don't know, as a NICU guy, you don't know what you are dealing with, the baby look blue, it doesn't look right for you, and you don't have an echo at that time, and it could be pulmonary hypertension as well as any congenital heart disease, just start your prostaglandin, make sure you will assure the persistence of the PDA, and you move on. Ductus venosus is not an important because it will close after birth with the special situations. The other second one is the foramen ovale, especially when the shunt is needed. So you need to have a good PFO and a good PDA, and the patient is doing all right until you take care of him. So prenatal diagnosis, this is how we started in 1970. This is all what we have when we do an ultrasound. I don't know if I was a doctor at that time, how I'm going to read this sparkles everywhere, and where is the heart? I don't even know. There is a baby, I don't even know where is he. So this is what we have in 1970. This is what we have right now in 2020. We can, and you saw the previous presentation from Dr. Briggs, that where the baby is telling us bye-bye and hi. And so we have gone so far in the diagnosis of congenital heart disease and congenital ultrasound, prenatal ultrasound altogether. So, you know, we even do an MRI right now, and, you know, we don't do it a lot for fetal heart just because they move a lot and they don't stay still. And we have gone also in genetic achievement that we started, you know, 1960s, 6 karyotypes, and then 90s we start doing fish. And now we can do the whole exome sequences, and Dr. Ayman Hattab is not here, otherwise he will tell us how beautiful this test, how much you can, you know, it will cost you your arm and leg, and you're going to go broke for another month or so, but you can do the exome sequence, which can diagnose almost most of the, you know, hereditary problems. So we have advanced both in technology and also in testing. So why do we screen? I think we have already, you know, mentioned that before. It's the most common lethal. So people die from it. If you don't diagnose properly, if you don't take care, patient die. So the first year of life, this is #1 cause of death of congenital anomalies. I mean, it's just so big for us to ignore or to put it in the back seat and we say it will be okay. So children die because of that. The most common congenital malformation, it's 1% overall. So we have every single, majority of congenital heart disease come, and this is the trick, because most of the time, oh, the mom has this, or the mom diabetic, or the mom have this. Most of the congenital heart disease come from normal mom. It's just like when you talk about Down syndrome patient, the majority is not the old woman. It's really the young woman who get Down syndrome because they produce more. So you end up by having more children with Down syndrome from younger woman than from a woman who has 35 years or older. So this is where we are right now from the ultrasound point of view, and how we need to think. There is different level, you know, level 1, level 2, and level 3, and that's how we approach. So level 1, theoretically anyone can detect, OB doctor, radiology doctor, they can detect the movement of the baby, the heart, pulsation and so on. And sometimes they extend to look at the fetal size and gestational age and cardiac position. And this is vary from country to country. Like if you are in US, probably the OB doctor will have more authority to do more of a scanning, and they will try even to scan the heart and look at the heart and other anomalies as well. If you are in different part of the world, the insurance will not pay, as an example. They will not allow you to build your skills. So how can you become good in detecting congenital anomaly, regardless if it's heart or not, if you cannot bill it to the insurance? You end up by letting it go. And then you depend on other people who can bill, but they may not know what you know. So, I will say maybe a radiologist will know less about congenital heart problem than maybe a fetal medicine person, but sometimes the billing is different story. So level 2, usually we go a little bit deeper, so we talk about fetal structural survey for chamber views, and usually that done by prenatologist and done also by radiologist. So we didn't reach really to the 3rd level. This is the end of the day where we can say we need this level of expertise to be able to exclude if there is congenital heart disease or not. And that's, as you see, fetal echocardiography usually done either by prenatologist, and thank you to Dr. Hussein and the group here, or by pediatric fetal cardiologist. Again, even in fetal medicine, not every single person in fetal medicine feel comfortable about the heart, and not all pediatric cardiologists also feel comfortable about the heart. So you have to ask the person who feel comfortable. I'm gonna send you a patient, do you feel comfortable with this kind of issues or no? So I think, so this is basically the way that we function. I think what we detect, basically, if you look at what you have here, if you include in your screening the 4th chamber and the outflow, you end up by having more than 75% of the total congenital heart anomalies. So you still have some that you may not detect. Yeah, and so what we need to answer you guys, what we need to tell you, when you send me a patient, you expect me to tell you something. What is it? So first of all, if the patient is normal, don't be overconfident. You have to tell the parents or the patient or the doctor who referred to you, the limitation of the fetal echo. It's not as easy as we showed it in our presentation today. It has a lot of challenges. So don't be overconfident and leave a space for, backup plan in the future. So why we have this, mention the limitation, small fees, you may not see it, partial anomalous vein and coarctation. This is the general limitation that we don't see in most of the congenital heart disease when we scan. And some details of congenital heart disease, like you have a heterotaxy, you cannot tell me I saw all the pulmonary vein and I saw which one is the appendage and where is the IVC and the SVC and all of this kind of very ridiculous and very much detailed area that we cannot say it with confidence enough. So, but usually I can tell the parents, this is what I see, and there is some areas I may not be able to see it, but most likely will not change the prognosis of your child. You have a hypoblast, but is the arch 2 millimeter or 1 millimeter? I may not, but we're already starting with a patient who have a hypoblast, so I can tell you, you're gonna be a single ventricle down the line. So if the patient, have abnormal finding, you have to sit really with the family and educate them. Remember, it takes us a lot of time just to detect. Imagine young people, 20, 25 years, come to you and they are talking to them about transposition of great arteries. I can ask a bunch of pediatricians in here, and maybe some of them will say, I don't know what does that mean or how it works. So I am sitting with them in 10 minutes. I'm trying to convince them that I give you all the information. So usually when I see the parents, I will for sure, when they have a congenital anomalies, I will tell them, go home, rest, relax, come back to me in a couple of weeks, let's sit down again. They will go to Dr. Google, they will sit with Dr. Google, and they will see Dr. Aram, and they will see Dr. Adult Cardiology as well, Dr. Hussam, Dr. Hussein. They will go shopping for 2 weeks. They are done with their shopping, they will come back to me, and they are ready to listen more, and they are more smart and to talk. So one of the things that I have got from many OB doctors that if I mention this, the insurance will not. We are not here to be judges for the insurance or for not anybody. We are here to state the fact for the patient. If you are worried about not to screen the patient because the insurance will not pay or pay, this is not medicine for us. We have to be honest. Even with the insurance people, we are not here to trick them, and I'm saying that from my heart. We are not here to trick them, and if the patient needs to pay, he needs to pay. You have to tell him this is the truth. I'm not here to try to minimize your... The good news, and this is very important, most of you may not know it. Not all, almost always, I never have any patient who has a severe congenital heart disease or critical congenital heart disease that hasn't been denied medical care. The government here, thanks to both Dubai and Abu Dhabi governments, they subsidize this patient for a special fund in Abu Dhabi and for some charity and so on. So if you I don't have anybody here from Al Jalila, but I do work in Al Jalila as well. So if we write in the patient, this is an emergency surgery, patient is done, Dr. Nermin is here. So if we write an emergency surgery for the patient, life-threatening, it's done. You don't need, so tell the truth, tell the patient this is what is the diagnosis, and there is a solution for it. The other thing you need, most of these patients are expat, like we are all expat, and some of them will have different plan. Some of them will, it will change their life when you tell them you have a hypoblast. They are here working for 5,000 a month, him and his wife, and now we have a child who's going to stay in the hospital for a whole month, who's going to talk with whom, we're going to take care of him, who's going to pay. So they may choose to travel before. This is another addition for us, good reason for us to tell the parents, they're home, they have their grandmother and their sister, and they have a good system. So yes, I will say yes, diagnose properly and let them choose. If they want to stay here, I have a very nice patient recently we just delivered, the same one that talking about, they are from UK. They said, no, we want to stay here. That's fine, that's their choice. That what I told them that you can go there, probably will have this and this and this care, kind of care. They choose to stay here. So parents need to know, if they are from Pakistan, as an example, or India or some places, maybe they don't have the facility to take care of this patient, then you have to tell them that. So diagnosing prenatally exceed a lot beyond the research that you will see in the paper in this part of the world. We have more problems for people when we are about 90% of the population are expats. So that's a huge main problem. And again, you always can seek help from pediatric cardiologists. We know the resources, we know where the patient can deliver, we know the patient what they can do. So, why do we consult the patient to, we have to tell them what's going on. Reassure them and tell them about what's going on with this patient. And then we'll offer to them, what to expect, where they're going to deliver. One very important thing, almost any hospital, theoretically, with the NICU capability should be able to, of course, with pediatric cardiology on the staff, should be able to handle any congenital heart disease. And I'm working in many hospitals, and I'm not worried of delivering a baby in any of this hospital, and I know I'll just take care of him in the best possible way, as long as I have a NICU backup. Okay, and so, the other thing that, when we talk to the parents, we'll explain to them. And the most important, again, I say it previously, most of the parents will say a simple word, why no one told me? if we diagnose after birth? Why no one told me? Dr. Oyram saw me 20 times and she charged me 20,000. No, not Dr. Oyram. And charged me, and I was involved, as a matter of fact, I was involved with a case that went to the DHA and court and all of these kind of things. And the guy was saying a simple thing. I got over 12, and that's real case, 12 ultrasound, and every time they were charging, he's working for 4,000 or 5,000, every time they were charging him 300 dirham for it, and all of them normal. How did this happen? You know, how can you tell that? Where is the mistake? Where is the problem? We are overconfident of calling normal. A lot of time we assume normality. Please learn in general term, not only in pediatric cardiology, not in fetal. Don't be over assuming you are coming to me, okay, you don't have pneumonia, you're just fine. No, I have to search, and it's always in medicine harder to prove to somebody he is okay than to tell him he has a transposition of great arteries. So, because to tell him it's okay, how did you know? What did you do? I mean, it's just telling you, if you come to me with chest pain, the same thing. You need me to prove you this is not a heart attack. So I will have to do 10 tests. If you have a heart attack, you're going to be in the cath lab the next 1 hour, and we are done with the discussion. Okay, so we spend a lot of time just to explain for the patient what's going on with them. And then we will decide, when we know the diagnosis, we'll plan for the surgery, where this patient can go for the surgery, and so on. By the way, very important, you know, until recently, I still keep hearing that, oh, you have hypoblast, there is no treatment, you have that, there is no treatment. We need to understand the whole fact before we say that. Almost every single congenital heart disease, there is no such thing, no treatment anymore. And in management, we theoretically can manage any congenital heart disease, like I mentioned before. And, you know, so one of the things that when the patient get a diagnosis, oh, I have to deliver in Jalil, I have to deliver in Sheikh Khalifa. That's not true. First of all, these two hospitals, they do not have a delivery. So, and the second thing, when the patient come, most of them will not be even diagnosed. And they will deliver in Ras Al Khaimah, they will deliver in Ajman, they will deliver wherever their luck will take them. So don't tell me we already planned everything in Ajman. Yeah, of course the doctor is here. Yes, we planned everything because he's with us here. Yeah, you know, we planned everything and we make everything possible for the post-delivery to expect anything in this world. Things just happen, and we have to be thoughtful how we are going to counsel the patient. So a lot of time people think that congenital heart is more difficult to manage. The truth is no. They are so beautiful kids. They are not symptomatic. As a matter of fact, I advise the family when I diagnose them prenatally with hypoblast or whatever it is, please hold your baby for 5-10 minutes before they go to NICU and they start putting the intubation if they do, or tubes, and then you can't hold your baby. Take a few pictures because it will take you 1 month later to have to hold your baby again. So please have this bonding with the mom and stay with her for 10 minutes and take a picture with the father and so on. They feel so happy when you tell them this kind of information that they will never have a chance without that. Which one is true? Patient cyanotic congenital heart disease baby usually looks cyanotic, and children with cyanotic heart disease will need oxygen and intubation. And it is recommended to do echo after birth for all children to exclude congenital heart disease. And critical congenital heart disease babies usually have respiratory distress. This is what do you think any of these statements is true? No, none of them true. So they are not more in distress. They are usually not cyanotic. We use the name, we abuse that name. To be cyanotic, you have to be less than 85% in oxygen, and most of them will not have that number. And then if they are dark color like me, then I will be 60 and still not, I'm cyanotic by nature because I'm more dark. You know what I'm saying? Well, if somebody else with a light color, they will look like, they are cyanotic in the 90s. So it's a subjective issue. We use the saturation. That's not a cyanosis. 90% doesn't mean you are cyanotic. So you have to look inside the mouth and in the eyes when you examine the patient. Okay, so recommendation to do echo after birth, it's not recommended for everyone for so many different reasons. You know, there is a lot of, development that can we do, screening, echoes and stuff like that. We look a little bit at it from different perspective. So this is the true statement. Congenital heart disease, including critical one, look normal and act normal. That's it, case closed. So when you have a baby born today, the one who's gonna die is not the one who's gonna go to the intensive care because he's breathing fast, because this one already give us a signal, I'm not doing okay. The one who's gonna die is the one you're gonna send him to his mom, they will go home next day, the coarctation will develop, and the patient will come back dead. So this is the one that will scare you the most. So they look normal and they act normal. This is a very important statement for you in order to, which of the following congenital heart diseases are not repairable? I think I already stated that to you. All the congenital heart diseases are repairable and without any exception. Of course, there is a different prognosis for each one of them. Hypoblast, this is like the worst nightmare on pediatric cardiology diagnosis. When you tell the parents this is a hypoblast patient, basically you are telling them you only have half heart, either right or left, regardless whatever the outcome. Probably for the right heart hypoplasia is better than the left, because the left is more prepared to be a systemic than the right. So if you have the left very small, then you really have a very significant problem. This patient will not go home. So this patient will stay. They will go from the hospital from Ajman directly to Jalila or to Sheikh Khalifa. After they get stabilized, they can stay 1 week and 2 weeks and 3 weeks, should you decide, and there is no bed. Do not promise the patient as soon as you are born, I'm gonna send you. They will be waiting for you. There will be nobody waiting for you, because they will have another person already before you waiting on the list. So there is a lot of waiting list, and you may not be able. So this patient, they will go through 3 treatments, 3 surgeries, and that will end up by 3 years, but the first surgery will take about 1 year or 2 years, it will be done in the first month of life, and usually the most difficult one. I'm not gonna go through the details. Transposition of great arteries, this is another patient who do not go home at all. They will stay and they will fix their surgery. Again, one of the most criteria that I like about it, the legs always more happy than the arms when we do the testing. And this is a different way. We just basically, switch the arteries and call it a day. That's all what it needs to be done. And this is a tetralogy follow. I think we already talked about it before. Truncus and tetralogy follow, most of the time they will be treated as 6 months or so, but sometimes we may need to do them early. Truncus, usually they will be, we will have surgery for them in the first month of life or so, whenever possible. This patient usually they don't need prostaglandin in general. I'm not going through the detail of how we're gonna treat them because we need to keep moving. This is another picture of the hypoblast, but it's in the right in this one. This patient also, if you don't have either, if you don't have right or left, most of the time you will need 3 surgeries and you will end up having a final surgery that tell you that we have divided. Coarctation of the aorta, very important diagnosis, usually easily missed, and we usually, we don't do the femoral pulse, and sometimes the saturation will be normal. If the PDA close, let's say you are here, if the PDA close, then the saturation here and here will be 100. The only way to detect this patient, even though you did your saturation 24 hours, saturation, 100 and 100 are okay, but then the patient will come back dead. The pulse oximetry, we still miss 1 out of 6, even though it's so good to detect critical congenital heart disease. However, keep in mind, please do not just take it for granted. Make it sure your nurses are doing it. And when they are doing it, they need to understand how critical and how important. And I am in pediatric cardiology, so I know patients coming to me, let's say with Glenn surgery, who are cyanotic by nature, and minors will write saturation 99. And that happened, and happened everywhere. And I can tell you many, many stories that where we can miss that the patient was, cyanotic and was not reported to be cyanotic, or have low saturation was not reported to be low saturation. And it will be a very important thing. AV canal is a very common thing, and usually with Down syndrome especially, this patient usually will repair them around 4 to 6 months also, sometimes before, sometimes after, depend on the anatomy. Ventricular septal defect, another patient who usually, this one will develop congestive heart failure, and AV canal will also develop a congestive heart failure, and usually about 4 months, 6 months, 8 months, depend on the anatomy, will do the surgery, but this patient, they can go home after birth. PDA and ESD. PDA, there's a lot of controversy for neonatal, the patient who's born with it, especially for premature, treat or no treat, and we are not talking about it right now. But after birth, if we diagnose it and it seems to be significant, usually we'll close it at 3 years or 4 years. We can close it before that if we need. Same thing for the ASD. We can close it around 3 years or 4 years of age. So what will you find if I write a report for you as a fetal medicine, as an OB, and as a neonatologist? Basically, you will find the most important answer for you. I will tell you, or we will tell you on fetal cardiology what to do. So the mode of the delivery, I'll tell you normal delivery, don't worry, go on. All right, I will answer you admission to the NICU or to the floor. So that's a very important answer for you. Of course, this is all guidelines for you. Things may change a little bit after birth. I will tell you if the oxygen is needed or not. Usually the oxygen in general term are not needed for any congenital heart disease with exception to some. And we will also, very important information, start patient on prostaglandin or not. As a matter of fact, nowadays we diagnose quite good number of congenital heart disease who need prostaglandin, and nobody call me anymore. They already have the diagnosis. I sleep, relax, next day it's a day. So they don't call me anymore for, usually we try to give a smaller dose of prostaglandin, like 0.02 or 0.03, to avoid the other side effect, the apnea and the seizure and the hypotension and all of these kind of things, and move on. The next day we'll do the echo for you. Time of cardiac consultation, we'll tell you that the patient needs to be seen immediately after birth, or I can see him next day, or I need to be with you during the time of the delivery, or I need to call Dr. Anas because we'll need cath for the patient directly to. So we will give you a lot of very, very, very important, very crucial information for you. And even we will mention if the patient will need a UAC with UVCs, because I don't want them to close and then we need to cut the patient and we lost a very important access. We'll give you all of that questions for you. And the need for intubation, of course, 99% of the patient, from the cardiac point of view, we don't want to intubate. Even when we transfer to a different, because people think that when you put a tube for someone, then you guarantee the delivery of the oxygen and so on. The matter of fact, you just put a tube and told them you are forced to breathe through this, and if you mess it up, you could die. So no, there is no need for intubation. Even if you transfer the patient, we transfer patient even to USA or to UK without intubation, and we make it sure the team that transporting understand the concept why. But you have to have a team who is able to intubate should we need. And usually the intubation, not because the patient needed for oxygenation, because theoretically their lung is good. So why should I intubate you? The main reason usually is the balance between the circulation from the lung and the body. That's the only reason from the cardiac point of view. Usually we will intubate. Of course, there is some other reasons not. And then the expected time of surgery. So I'll tell you if the patient can go home after, and then the surgery will be done at 3 months, or the patient will have surgery after birth right away, and so on. Possible going home or not, and how to contact us. Usually we'll write a number. If I see one of your patients, I will write a number in the bottom. You can call me directly. You can give it, share it with the patient, share it with the NICU team, and so on. So take-home message, fetal echo is essential for detection of congenital heart disease, and it could improve the outcome. And counseling patient is very important, and understanding the resources around you is also very important. Know where is the patient can go, who's the genetic doctor, who's the fetal medicine doctor, who's the OB doctor, who's the neonatologist, where you're going to deliver, and all of these kind of things. And that's it. Please, you join us for next year for our conference. It's hopefully going to be in Abu Dhabi. Thank you very much.